I'm going to introduce for you 3D pathology. That means the following. Colleague takes out a piece of tissue, let's say segmentectomy, lumpectomy, doesn't matter what you call it. Now, the colleagues, the pathologists, are taking 4-micron thin slices in order to be able to see the cells and in the duct and the TDLU and the cancer. But 3D pathology means that we have a thick section called subgross that is 1500, 2000 micron. This is already 1.5 millimeter. A colleague, a pathologist, can, let's say, slice through a cyst. Well, actually, he or she is going to see a ring because here is a spherical cavity and they slice a 4-micron. But 3D pathology means that you can see the spherical cavity. Or our friend, a duct is going to be like a railroad on a 4-micron. But on the 3D, it's going to be a tube. And it bends here. It doesn't matter because you have the depth. The next thing is we have a lot of problems in imaging benign and malignant breast diseases because they are extremely complex. Could I ask, for example, any of the surgical colleagues? When the pathologist writes the diagnosis, radial scar, could you say a meaning? What is radial scar? Or what is fibroadenoma? What is papilloma? Fibrocystic change. Dear colleagues, I am going to teach you structural changes. So the colleagues, the pathologists, looking at their 4-micron slice, they can see cells. We radiologists go to a meeting with the pathologists where the colleagues are only talking about cells. When was it last time you saw cells on the mammogram? Never. MR, ultrasound. The surgeons do not feel cells, but a cancer-filled duct, let's call it comedo, they can feel it. The radiologists can see ducts, they can see terminal ductal lobular units. If the radiologists and the surgeons only experience structure, and we are talking with the colleagues, the pathologists, who only talk about cells, I think there is a gap in the communication. And you know what? Ingenious 3D pathology is bridging the gap. Let's go on. Fibrocystic change. This yellow background is fibrosis. And these bubbles are the cysts, microcystic fibrocystic change, which actually stagnates. Look at your deep pocket. In that, there are coins. And these are some body like onion ring, like laminated calcifications. That's sediment here. On the mammogram, we are going to see this, the whole thing, not the details, just this, as teacup, tea source, like calcifications. We take a picture from above, and we are going to see a breakfast plate seen from above, without the details. So you see, when we have this picture and this picture in 90 degree, then we say, sure, dense breast, which means fibrosis, and this must be in the bottom of a lake we call cyst, fibrocystic change. What is a fibroadenoma? We are going to detail all these. Extreme proliferation of the intralobular connective tissue. Can cancer develop out of fibroadenoma? Sure, although it happens very seldom, because what is cancer? The malignant proliferation of the epithelial cells. So here is the terminal ductal lobular unit, within which the intralobular connective tissue proliferates to the extent that it becomes a tumor. I'm going to talk about in a second. I'm referring to a lovely, jovial Englishman, a colleague, Dr. Hughes, 35 years ago. He named the hyperplastic breast changes Andes. He meant that in the middle of the menstrual cycle, this little guy, I'm going to show the 3D picture of it immediately. This is the terminal duct. These are the acini or lobule, terminal, ductal, lobular unit. That's where the milk is produced. And there are thousands of them. They got a little bit excited in the middle of the menstrual cycle. That's called proliferation. They are sending a message to the sleeping neighbor. Wake up. Hopefully she becomes pregnant. So we are going to go to work. There is secretion. So they prepare themselves for producing milk. And of course, pregnancy is not that frequently occurring. So proliferation is going to be replaced with involution. And it goes up and it goes down and it goes up and it goes down for a few decades. What I want to say and what Dr. Hughes wants to say is that during the proliferation and involution and proliferation and involution, things can go wrong. And dear colleagues, this is what is called hyperplastic breast changes. Aberration of normal proliferation and involution, ANDI. Most of the pathological lesions and events happen in the terminal ductal lobular unit. You see, this is a duct. This is a terminal duct. And imagine that you have rubber gloves with 50 fingers. Nevertheless, the size of this is not more than 1.5 millimeter. This little guy has 50 acini. Acinus, acini. Most of the hyperplastic breast changes and these actually originate from here. And do you know what percentage of the breast cancers originate from the same? These cells one day produce the milk. 70 to 75% of all breast cancer originate from the acini when the luminal cells become cancer cells. Why do they call them DCIS? It's carcinoma in situ. But this is not a duct. That's an acinus, correct? And when the basement membrane is dissolved and the radiologist is going to see a stellate lesion, the colleagues, the pathologists call it invasive ductal carcinoma. Excuse me. Is there any other basic building block wherefrom hyperplastic breast changes can develop? Yes. From the ducts, there will be two, the papilloma and the radial scar. And from this yellow background, the fibrosis. Have you ever heard the term PASH? Of course, the colleagues, the pathologists, understand it's pseudo-angiomatous stromal hyperplasia, PASH. It's increased fibrosis. I was just telling you this ups and downs as the luminal cells start to produce fluid. And because they got a little bit too excited, they produce too much fluid. And when the involution comes, they cannot go back. What's the name of it? Focal fluid collection and a little bit of fibrosis in the background. Fibrocystic change. What if among the fingers, as I mentioned to you, the interlobular connective tissue start to proliferate and proliferates and proliferates to the extent that it becomes a tumor? You know, Latin, all of us, benign or malignant, finishes the word oma, papilloma, carcinoma, and so on. But in this case, we know where the proliferation takes place, in the gland, in Latin, adenoma. What proliferates? Fibrosis. What is fibroadenoma? Always start the sentence with this. Fibroadenoma, or fibrocystic change, or radioscar, is one of the hyperplastic breast changes where the intralobular connective tissue proliferates. Here is histology, to the extent that it forms a benign tumor. What is fibrocystic change? Is one of the hyperplastic breast changes where the luminal cells change to apocrine metaplastic cells that produce too much fluid, and cystic, small or large, cavities are going to develop. This is going to be a little bit more difficult. What is adenosis? Now imagine that the rubber gloves you have in your hand had 50, 60 fingers. Now it has 120. When it's more, what's the Latin name of it? It's called proliferation or hyperplasia. But at the same time, it becomes big. So, what is simple adenosis, which we see on the mammogram? We call it pattern 4, high risk. This, like snowflakes, pattern 4 never changes. 12% of the population has it. Simple adenosis. So what is adenosis? One of the hyperplastic breast changes characterized by the hyperplasia and hypertrophy of the TDLU. Now I'm adding one more word, or colleagues, the pathologists, add. What is sclerosing adenosis? If I was asking kindly the surgical colleagues, you went to the tumor board and they say, yeah, and sclerosing adenosis. Did you understand what they say? What is sclerosing adenosis? One of the hyperplastic breast changes where there is a hyperplasia and hypertrophy of the TDLU, plus the intralobular connective tissue proliferates, and it's strangling the proliferating acini. You grab the finger of your rubber gloves and pull it out. It's not distended, no, because the surrounding intralobular connective tissue does not allow it, strangles it. Sclerosing adenosis, why is it important for the radiologist? Because inside here, a tiny little droplet of fluid is going to form a crystal, some homobody-like calcification, and this measures about 40 micron. We radiologists cannot see anything under 100 micron, so many of these tiny crystals are going to give us the powdery calcification, cotton ball-like. You walk on a cotton field, you cannot see the fibers, right? But you see the ball. Now we are in trouble because we see this on a region that occupies a whole lobe like this. And then the colleagues, the surgeons, come by and they say, would you mind doing core biopsy on this? Well, I don't like to do that because many times the calcification is there where there is sclerosing adenosis, but a non-calcified carcinoma may be there. The radiologist must do ultrasound to find this guy. Still, we miss it. But the problem is that in 50% of the presence of cotton ball-like calcification, it's going to be grade 1 cancer in situ within the TDLU. And in 50% of the cases, it's going to be sclerosing adenosis. While we are going to talk about real malignant type calcifications with necrosis, we would very much like to talk you into cutting much more than what we can see. Here, we are going to say, well, could you just do diagnostic biopsy? Very difficult. This is all because of this problem we call hyperplastic breast changes. What is blunt duct adenosis? Yeah, one of the hyperplastic breast changes where there is a hyperplasia, a hypertrophy of the TDLU. Plus, look at this proliferation. I mean, it's a very good description by the pathology books. You have a thumb here, but tomorrow you have another thumb. And after tomorrow you have another thumb. Proliferation, kind of blunt. This is the three-dimensional picture. Sclerosing adenosis is skinny. This is blunt. So much about the hyperplastic breast changes originating from the TDL. And here is the beautiful three-dimensional picture of the crystals, some of my body-like calcifications. Now we go to the duct. The duct is not as friendly as the TDLU. It only has 2 hyperplastic breast changes. Now we are in trouble again, because we fear everything that has architectural distortion. It can be a killing cancer, it can be the diffusely invasive carcinoma, and it can be just a radial scar. And so fortunately in the 21st century, the radiologists have a toolbox full of tools: the core biopsy, the ultrasound, the MR, good mammography, and so on. And what is the last one here? Papilloma. You see here is the basement membrane, and this guy swimming here is the papilloma. We will talk about all these. We have to perform galactography, which doesn't exist in your country. So I'm going to pull the legs of the surgeons. What are you doing when she comes with serous or bloody nipple discharge? Oh yeah, I just do this periareolar section and then I take a little piece of tissue out. Whoops, I just missed the papilloma. What doesn't matter because I put a suture here. So the symptom is going to disappear, but the disease is laughing at you. We'll talk about this as well. I encourage your radiologists, introduce galactography in your country. So the NDs either produce fluid, and then we call it cysts. But you see, here's the problem for the radiologist. Cysts are extremely sharply outlined. The problem is that it's called fibrocystic change. So I don't see it as a sharply outlined. I have to use ultrasound. And then I can see it as sharply outlined without intracystic tumor. And then, when it stagnates, then calcifications are going to be formed in a cluster. And a good radiologist also looks at how close the calcifications are, their density, size. They are tiny microcalcifications. Grade 2 carcinoma in situ with necrosis is produced within the TDLU. And so the calcification is going to be very much like the calcification in fibrocystic change. Likewise, when fibroadenoma is aging, then hyalinization takes place. Here we go again. Cluster irregular calcifications. Anxiety level goes up. But you see, don't worry. We have core biopsy, stereo biopsy in our toolbox. Papilloma, same thing. Hyalinization, cluster calcifications. We have 3 contender to grade 2 cancer in situ within the TDLU. And of course, radiologists always think about cancer, but that's much more seldom than the 3 hyperplastic breast changes. I don't tell them that they should agonize. I tell them, don't agonize. That's why we have the core biopsy and a stereo biopsy. And then the surgeon is going to decide whether this half-dead papilloma and fibroadenoma should come out. I just talked about the powdery calcifications and the radial scar. So now sit back, relax, and I'm showing these 3-dimensional things I promised to you. I guarantee you, even if you're a well-trained pathologist, you have never seen pictures like this. When I'm saying structure, we don't need to be physicians to say this is a tube, this is a duct. And I'm always referring to comparisons like a tree or a bush. There are few branches and there are zillions of leaves. This one is called the duct. This one is called the leaves on the tree. That produces the milk. And that's where most of the cancers are produced. And so imagine that the size of this is 1.5 millimeter. These two we call the glandular tissue, this one and that one. As if you were stretching your arm out, your forearm is the duct, and your hand with 50 fingers is the terminal ductal lobular unit. There is this yellow stuff we radiologists hate because it covers everything. That's called fibrosis, and this white stuff is called fat. So the four basic building blocks are right in front of you, and pathology means that a collection of fluid, collection of cancer cells is going to distend and distort this beautiful structure. Just one word about the Cooper's ligament. Well, Cooper was a very smart surgeon in the middle of 1800. He published 2 books, and a year, 2 years later, he died. Wonderful book. But Cooper was much smarter than giving his name to ligament. Dear colleagues, this is not a ligament. It actually contains duct, one of the basic building blocks, duct. It contains many terminal ductal lobular units, second, and you see the yellow background? That's fibrosis. When we see 3 out of the 4 basic building blocks, or let's add fat to it, 4 out of 4, that's a breast tissue. So Cooper's ligament is not a ligament. Cooper's ligament is a breast tissue of which malignant and benign diseases can develop. So much about that. When these acini are producing too much fluid, then it goes through the terminal duct, and you see this one is fluid. And of course, this is distended duct ectasia. Beautiful. These are still fingers. But when you force fluid or cancer cells into rubber gloves, just think about it. You blow air into it. The fingers are going to be chubby, thick, and there are no fingers anymore. There is a cyst. Tiny, that's fine. Here is the fluid in the subsegmental duct. Enjoy looking at this. Radiologists, when they're performing ultrasound, can see these small holes, hundreds and hundreds of, at women who come with mastodenia. And I'm sure that the colleagues, the surgeons, are very much bothered by the complaint. Breast pain. This is one of the most frequent so-called diseases in the world. The reason for this is that this is fluid, and if you compress the breast, God should help her. She goes to mammography and squeezed. She's not going to be a happy camper, probably never comes back. And the reason is that you cannot compress fluid. It comes the energy, and then the fluid says, I'm passing it over to my neighbor, which is full of nerves. Pain is the explanation here. You're going to see that the ducts look like a saguaro cactus, pleated. Why? Because Mother Nature knows that when she is going to lactate, the milk is produced here. But here in the factory, there is not enough room to store it. The milk is going to be stored in the ducts, which means that the pleated nature provides the opportunity of distending. And this one I put in because you see the normal and the normal and the normal TDLUs. Here, there is duct ectasia and microcysts. Can you imagine that the technologists have taken a picture of this And please respect your poor radiologist. It's difficult to read a mammogram because we are imaging pathology, and a picture under this square inch is different from the picture under this, and it's very different from this. That's why it's so difficult to read a mammogram, because of the heterogeneous nature. I mean, just imagine what a liver looks like. Very homogeneous. Here and there and there and there is the same. Now we are moving towards winter. That is, what happens with the branches of the tree in the winter? They are not going to decrease in number at all, but they become skinny, pleated. And the TDLU say, goodbye, atrophy it's called. You see the fat, you see the fibrosis. Here is a fibroadenoma in the making. You see the fibrosis? And this is an entrapped acini. So yes, carcinoma can theoretically and very seldom develop in a fibroadenoma, but in most of the cases it's going to be LCIS or grade 1 or grade 2 cancer in situ within the TDLU, not ductal. And you see the millimeter scale here. Now it's winter time. Well, we radiologists would be very happy about it, but we are not, because there is only so little fat. This is our friend, the red stuff, called dense breast. But then, once again, the breast is not contiguously wintertime here. I'm moving this 10 by 8 centimeter glass with the tissue on it, and look what I find. This half wintertime, this half springtime. And that explains why women with dense breast can get a breast cancer. Hyperplastic breast change, name it. Look here, total springtime, fantastic. Let's explain the hyperplastic breast changes in 3D. Within the acini, the cells become long, cylindric, apocrine-metaplastic cells. I don't see cells on the mammogram, and I don't see cells on the 3D either. So these apocrine-metaplastic cells form a little bit of a micropapillary proliferation here. Mind you, this is the size of a normal TDLU. This inflatable the TDLU can be. This used to be a single acinus, which I don't even see here. But look how inflatable. But of course, the fluid that distends the acinus is going to distend the terminal duct and is going to distend the subsegmental duct. Very cute pictures you are going to see now. How come that apocrine-metaplasia influences this TDLU, but leaves this? We always talk about the hormones. How come? Hormones are in the blood. How come that these reacted and these are not reacting, the so-called hormones? Microcystic fibrocystic change. Please note, this is fibrosis. This is cyst. Fibrocystic change. And then you can get very cute pictures. This is ductectasia, microcystic, more larger or varying size of cystic dilatations. And here's a bird. Fibrocystic change. Ductectasia, fibrocystic change, mastodynia, breast pain, small, large. Here is a problem. Whenever fluid stagnates, then calcification can be formed. Dear colleagues, this is a problem for the radiologist. Here is the mammogram. One cluster, discernible calcifications. And then, of course, the anxiety level goes up because it could be grade 2 cancer in situ with necrosis, but it could be fibrocystic change, papilloma, and fibroadenoma, right? Which one is that? In this case, this is fibrocystic change. Now we are at adenosis. microcystic adenosis, blunt duct adenosis. This is really adenosis. You see the fingers like this. And here is the control group for you. This is normal. And this is adenosis. So let me show you then sclerosing adenosis. Here it is. How many acini? Many. Hyperplasia, hypertrophy. I don't care as a radiologist until there is oyster pearl-like calcification. And then the anxiety level goes up. You know this. Blunt duct adenosis. Fantastic. Here is a thumb and here is a thumb. Now tell me what this is. The size is 7 millimeter. The acini are distended. One acinus measures 1 millimeter. Normally, a whole TDLU measures 1 millimeter. And what distends this? The pathologist would say solid cell proliferation of cancer cells, necrosis, and if you radiologists are lucky, then here is the calcification. Here is a calcification, but there is no calcification here. There is one here. There is one there. And they are so small, we call them microcalcifications. And they are very close to each other. So when we are going to analyze the cluster discernible calcifications, the closeness is going to be an important diagnostic trick. Let me magnify this now. Here is the problem with the small section histopathology. The colleagues, the pathologists, are jacking up the magnification factor, and they think that this enormously distended acinus is a duct. Dear colleagues, this is not a duct. This is a distended acinus. So there is no justification for using this word, DCIS. It's a cancer in situ because the basement membrane still holds. But this is not a duct. The diagnosis DCIS in 75% of the cases wrong. And this is causing a lot of problem all over the world. If the cancer cells originate from the major lactiferous duct, yes, it's ductal. But you see, by the time we find it, just like a saguaro cactus, it has a side arm, so it's not cancer in situ. It's ductal, but not cancer in situ. This is cancer in situ, but not ductal. Excuse me? What's the meaning of DCIS? None. This is blood vessel. The cancer cells are sending out a message, give me food, I want to grow. Now you understand, this is the calcification, this one, that one. Surgeons don't operate the calcifications, operate the patient.